Thank you for your introduction, Federico. I really liked the introduction before, too. I'd like to say that, too. Conferences like these are popping up like mushrooms in the autumn forest all over the world, the Western world. This is reflecting the...
Maybe.
Yeah.
Yeah, you should.
Okay.
Or
Okay.
you can use the microphone.
Reflecting the growing interest in the public as well as in the professional world when it comes to psychedelics. So it's only logical that Switzerland should host such a national conference, and I really hope that the Alps Conference can establish itself and be repeated again and again and grow and thrive and contribute to spread information and knowledge about psychedelics. It's therefore an honor for me to give you the first lecture at this conference. And there are basically three reasons why I can stand here and talk to you about the psychedelic-assisted psychotherapy with MDMA and LSD in a group therapy model. The first reason is that in our MDMA PTSD studies, we had several non-responders. And they desperately wanted to continue their therapy. And we found a way with this so-called compassionate use licenses to continue. The second reason is that we had leftovers from the study. So we were able to use these leftovers of MDMA and also LSD afterwards to begin with the compassionate use therapies. And the third reason is that using a group model brought me together with my friend and his colleague, Peter Gasser, because, as you know, psychedelic-assisted therapy is very time-consuming, and you need a day or more per patient. And we were convinced, also because of our experiences from older times, that a group model would be safe and efficient and feasible to perform. So I'll cover shortly the history of the group model and tell you something about the practical matters of the restricted medical use of scheduled substances in Switzerland, go on to what is needed from therapists and also from the patients, and tell you about the basics of this group model and cover at the end the main outcomes. So, the group model is not a new invention. Already in the late 80s, during a 5-year phase where licenses for MDMA and LSD were issued to a handful of Swiss psychiatrists, the group setting was already used. An interview study conducted by Jungabel and Veres with about a dozen therapists who were involved during this phase showed that at that time there was already a broad consensus regarding therapeutic standards and interventions and the basic rules that govern this kind of therapy. Moreover, the authors at that time already emphasized that psychedelic-assisted therapy is rule-governed and in accordance with the general principles of action of psychotherapy and the consistency theory of psychotherapy as formulated by Klaus Garve. So in Switzerland, we have the very unique and enviable situation that the federal narcotics law allows for this exceptional license. I'll talk about the procedures, how to get such a license. These are very practical matters. They are simple, but also strict. So beforehand, you have to check your insurance, if your professional liability insurance will cover such therapies. As far as I know, most insurance companies consider psychedelic therapies as off-label use of medications, so that's not a big problem. Then you have to apply to the Federal Office of Public Health with a detailed report or application and describe why you want to use LSD or MDMA or psilocybin to treat somebody. Then you have to mention the supply of the substances. In our case, it's the Department of Pharmacology in Basel, and you have to enclose an informed consent signed by the patient. Then you get a temporary license, usually for half a year or a year, and you are required to give reports at the end of the time the license runs and to apply for a renewal. So it's not a very difficult way, and it's a bit of paperwork, but the gain we have from that, we'll do it gladly. I skipped a slide I saw. I'll say something about the history again. Now, during that phase in 1988 to 93, after that, there was also a training group that was sponsored by SÄPT. And after this, the studies of Peter Gasser and mine finished, we started with first single sessions, and Peter then requested the Federal Office of Public Health to allow for small groups, which he did. He did 2 or 3 groups, and then reported to them, and they allowed us then to continue with larger groups. We had a group together that ran from 2014 or 15 up till the end of the 2020 when I closed my private practice. I had a second smaller group with a slightly different format. I'll talk about that later. Now, today this year, there are about 30 Swiss psychotherapists, psychiatrists who have licenses who are already working with these substances. This is very special and unique, as I have told you, and in other parts of Europe and the US, there exist several expanded access programs, they are called, mainly in the USA or in the UK. I'm not informed how far they are or if they're still, or if they're already working. So, until a few years ago, therapist qualifications were not a big issue. Previously, the effects of psychedelics were referred to as dependent on the dose setting thing, and the therapist or the guide was more or less ignored or not talked about too much. Now, that research is rapidly expanding and the approval of MDMA is just around the corner. The role and qualifications of therapists are coming more into focus. So maybe it's time to move from the dose-set setting to what I'd like to call the 4S, meaning set, substance, situ, and setting. We, in our work during the last 6 years, observed and learned that there is, especially with severely ill patients that we have been treating, there's a continuous and subtle nonverbal communication going on, and which is decisively influenced by the personality and professionalism of the therapist. There are a growing number of trainings in psychedelic-assisted therapy being offered in North America and Europe. I'd like to mention the MAPS training, the CIIS training in California, also the Mind Foundation training here in Europe, and the SÄPT training. Only to mention a few, there are several others, as I'm informed. Now, Janice Phelps, in her article about guidelines and competencies in the training of psychedelic therapists, collected what the pioneers, the giants, and experts in the psychedelic field had to say about this. And she distinguished 6 competencies that a psychedelic therapist must have. The first competency is called empathetic abiding presence, and together with the second one, trust enhancement, and the 5th one are the most important from my point of view when it comes to being a psychedelic therapist. The first one means to have to listening, to being present with evenly suspended attention, mindfulness, composure, by doing nothing, and responding to distress with calmness and equanimity. It's all about an overall good balance of mindfulness, protection, permission, and connection. The second competency, trust enhancement, not only refers to the therapeutic relationship, but also the trusting of the therapist and the patient in the psychedelic process itself, meaning you will come to an end or you will come to a goal if you trust, if you can let go, if you can allow yourself to engage in the process, despite all the unexpected twists and turns such a psychedelic journey can take. The therapist's spiritual intelligence and knowledge is needed to accompany and support people experiencing mystical type experiences under psychedelics. This goes beyond normal psychological knowledge and means appreciating and validating the transpersonal and spiritual realm. Of course, psychedelic therapists must have a broad knowledge of the effects of psychedelics in the narrower sense of neurobiological effect, drug effects, risks, side effects, the pitfalls, but also have a proficiency in developmental psychology, a good basic psychotherapy training. They must also know about indigenous shamanistic psychedelic healing cultures. And almost all experts in the field emphasize the importance of guides and therapists having had psychedelic experiences by themselves. Therapist self-awareness and ethical integrity includes being aware of one's own motivations and intentions. Skills in dealing with transference and counter-transference issues are crucial. There's a need for continuous self-critical reflection of the process, professional exchange between colleagues and in teams, and being aware of compassion burnout, the pitfalls of narcissistic grandiosity and idealization, the abuse of power, and dealing with sexual attraction are all part of a high level of ethical integrity of the psychedelic therapist. And last but not least, the proficient psychedelic therapist should also have a large skills or toolbox of methods and technique in the background to deal with all the unexpected things that can happen on this journey. So, what are the patient requirements? I think it is crucial to carefully select and prepare patients. One of the things we came across is to not take on people who are emotionally unstable or too impulsive in an outpatient setting. It's very tiring handling these people. It's not impossible, but maybe they're more suited to be treated in an inpatient setting where you have a team that can handle the aftermaths of a psychedelic experience. It is clear that when treating treatment-resistant patients, most of them have had years and even decades of futile psychotherapy. What you have to check is if they are willing to face emotional distress and really bad traumatic material, if they know about it, and if they are willing to endure the emotions that accompany these memories and things that had happened to them. And patients must be compliant and reliable if they have to do their homework, and it is useful to test this before engaging in psychotherapy, in psychedelic psychotherapy with them. When it comes to a crisis, the therapist must be sure that the patient hangs on, that he does the work, that he calls when there are suicidal thoughts coming up, and things like that. So, the way I performed psychedelic-assisted therapy is that I mostly began with MDMA. This is mainly the reason because I worked with trauma-related disorders, and from my point of view, it is easier for severely traumatized patients to begin psychedelic therapy with MDMA. It's easier to handle, it's not so frightening, and these patients need to settle into this method. They need to get to learn altered states of consciousness. They need to learn how such a process evolves over time. They need to learn to be part of a therapeutic group. They need to learn how to develop their self-observational and verbal expression capacities, and how to handle confrontation and extreme distress situations. When they are comfortable, most of them will at some point say, "Oh, I'm ready for LSD now." and that's the moment to move on to LSD. And my observations of treating, for example, complex PTSD was that you won't get through with MDMA with these people because they have such deeply rooted negative convictions and beliefs about what had happened to them, how negative they are, and this won't change with MDMA only. It's also easier to handle the structural dissociation with LSD. This was a rather extraordinary observation I made. Structural dissociation stayed more or less the same under MDMA, but started to disappear under LSD. I haven't thought about it theoretically, but it's an observation worth thinking about in the future. And to really challenge and change these convictions, you need a hallucinogen. And when reading the protocols and reports from patients, you can then pinpoint when it really gets to start to deeply change them, when you start with LSD. The primary focus is in this kind of therapy is on the therapeutic process, not on the altered states of consciousness or mystical type experiences. This is nice to have, but we want them to get better, to lose their symptoms, to reintegrate themselves into society and go on with their life. So, Peter and I also use the individual setting, which shows a quite lesser degree of complexity versus the group setting. The special indications are in cases where people are just too scared or are so out of line that they cannot participate in groups yet. Or if they need a high level of one-to-one support, you have to sit with them the whole time and be at an arm's length with them. Or if you use high dose of psychedelics, that means 300, 200, 300, 400 micrograms. People will be not able to participate in the group process during the peak experience and are often then disturbed by what's going on in a group. Or if a psychiatrist wants to delegate the sessions to his staff and assistants, maybe it's good to do this in an individual setting. And then, at last, specific issues like dealing with the fear of closeness can be more efficiently dealt with in a one-to-one setting. In a group, they can disappear or they can avoid being close with anyone. And in a one-to-one setting, the therapist is here and he's always in the focus, and this question of closeness stays in the room. Or if you have very, very complex and severe disorders, the group setting is not the correct one. Of course, as I said, the individual setting has also disadvantages. It's the time and effort that is needed. It's the cost. Psychedelic-assisted therapy is not covered by the health insurance. They have to pay by themselves for it. And it's a full day of a doctor they have to pay. We can charge the insurance a part of it. They have to pay for the substances, which are at the moment still very expensive. And you don't have group interactions, which are very informative, instructing, and helpful in the healing of patients. So, what are the advantages of a group model? It's definitely less strenuous for therapists to work in a small team of 2 or 3 or even 4 therapists and sitters. We can share our tasks and responsibilities. And when it comes to dealing with transference issues, for example, it's easier to handle because somebody can jump in, moderate the situation, or replace the therapist so the psychedelic process can move on. I'd like to remind you that already Stanislav Grof, I think it was in his book LSD Psychotherapy, referred to transference problems as a complication of psychedelic therapies. It's not the goal. We want to avoid these transference things. They're no use. It's a waste of time therapeutically in this kind of therapy. So working in a group with this makes it easier to deal with these things. Then there are a lot of advantages for the patients. They have mutual support and feedback from their peers. For many people who are severely traumatized, it's the first time that they feel something like a community, or what it is to be part of a family, or to be close, or to relate to each other. And they usually develop friendships and develop their own small network of supporting relationships where they call each other with minor problems, and they figure out what they do without their therapists. Elder, the more experienced peers are often role models for the younger ones. And often enough, in these groups, we have common topics like, how do you deal with fear? How do you deal with shame? How do you deal with this or that? And often enough, during one particular session, there's one such topic that dominates the reports of the patients, and you can pick it up and work with it under the influence of the drugs and afterwards during integration. What are the challenges of this model? A need for group rules. There are 2 important reasons for group rules. One is that the groups should stay together during the whole session and go through the psychedelic process together. And the second reason is that everyone gets enough time and space, and not only the loud and noisy people get all the attention, so that the silent and quiet people also can be heard in these groups. So when using LSD and MDMA on the same sessions, there is a need to coordinate the effects, to coordinate and balance the individual needs in respect to stillness, talking, or moving around. And you need to also balance and coordinate the individual substance-related openness and permeability, which is much higher on the perception level with LSD than with MDMA. So you need rules. For example, one rule is the first half of the day, everybody is on his mat and is busy with his own process. The second half of the day, you can go visit somebody else. You can see how it feels with your neighbor, or if you have to talk with somebody, you can do that later on. So you have to have rules about noise and restlessness. There are, I think, 4 or 5 basic fear triggers, which are inborn. The first one is noise. So if we get startled, we get automatically startled by noise. Like these PET bottles, if they snap on the peak with 200 LSD, you might have a heart attack. So you have to have the rule of how to deal with these things. Talking is not a problem, but if it's used to avoid going deeper, it becomes a problem and will disturb everybody in a group. I mentioned transference issues. Another problem is the integration of more egocentric individuals or participants. They don't like to follow rules. They like to do their own thing. They attract more attention than others, and you have to be a bit diplomatic to have them, to pull them in and face their own stuff and be a normal group member. And the last thing I would like to mention is that in our common group, we were 3 therapists, we had we had different therapeutic styles, and we disagreed on some stuff, and were maybe 80 or 90% we were on the same line, but this can also be difficult when it comes to tricky situations. So you have to have a constant feedback with your colleagues when working in a group model. So how did we do this? We had 4 or 5 group sessions per year in 2 or 3 months apart. And we had one-to-one sessions, if individual sessions, if necessary, in between, or if somebody would not be able to participate. All group therapies were embedded in ongoing individual psychotherapy, and the doses of the substances were 75 to 125 milligrams MDMA, sometimes with a booster of another 62.5 after 2 or 3 hours, and with LSD usually in between 100 and 200 micrograms. Exceptionally, we went higher with people suffering from OCD, for example. Sometimes people wanted to participate but not take any substance, and they were struck by what such a group setting does to their consciousness. There's something like a contact high that happens. You can, as a guide, you can observe this yourself. Your mind starts to your mind goes in a slight trip, like about 25 micrograms of LSD, and you float with them. And people also appreciate this kind of taking in the perspective of therapists and still being a participant. This is an interesting thing that can help the therapy get on. We took on mostly up to 14 patients. Mostly it was between 10 and 12, and we were 3 therapists, of which one was a female. This is important to have a woman on board in the therapeutic team because of these cases where people have to, or women have to deal with sexual abuse in their history and sometimes refuse to be approached by men, by a male therapist. So we had a 3-day format in the large group, and in the second group I had a 1-day format. And with the 3-day format, we had a preparatory session the evening before, with everybody telling the group how they were doing, what their problems are, what their intentions for the next day was. It's coming together, and then followed by the full-day group sessions from 9:30 to about 7 o'clock, which is then the time for a picnic in the middle of the group room. And after that, people can leave, go home or to their hotel or whatever, or they can stay in the group room and talk together, and the therapists go home. And the next day is the sharing and integrative group talking sessions of about 4 hours, where we make a first integration effort to sort things out, what had happened the day before, to give feedback, to get feedback from each other, and to clear misunderstandings. There are a lot of misunderstandings that can happen in groups, not only psychedelic groups, but that's something very human. And they then are required to write a protocol of their experience, which can be used in the consecutive therapy. They get the playlist of the music, or the older ones, good old CD. The music is an important part there. It helps them tune back into the experience when they're at home, listen to the music, and they have a sort of small therapeutic flashback that the music played can help them go back to what they experienced and start to more and more integrate it. The therapists are, of course, available in the case of crisis for the following days. So I've tried to put the patient characteristics into this table. Peter and I had both about 24 licenses in this period from 2014 and to 2020, and you can see on the that I had mostly trauma-related disorders such as PTSD or complex PTSD and depression, whereas Peter had more people with anxiety disorders, cluster headache, and depression. Most of them had a mixture of group and individual sessions. Most of them experienced both substances at some point, and we did not have any severe adverse events, except one patient who had to be hospitalized for some somatic reason that coincided with the session. One of mine patients had a paranoid episode of maybe 1 to 2 weeks following an LSD experience, but it turned out that was related to her trauma. She was so scared to death that she'd rather go paranoid than face it, and careful confrontation afterwards reduced the fear so she could face what had happened, or her memory. She could face the memory of what had happened. So this is a very coarse assessment of the outcomes. I'm happy that nobody deteriorated during these therapies. I had 3 patients that I have to say they did not improve. One was a dropout. It was a woman with a very bad case of OCD, and she would not continue for multiple reasons. And another patient had such a severe depression that we didn't have the time to get to improve him. He would have needed many more sessions. And so clinical improvement or remission was in most cases to be seen. So I'd like to give you two quotes from participants. The first one is a 58-year-old woman suffering from complex PTSD. I was a very lonely and disconnected person before I joined the group. The group helped me to open up, to be close to others, to express myself, and to build relationships. I realized that other people also had severe problems, and to listen to them and watch them change was fascinating and enlightening. To talk to the group about all the bad and painful things that had happened to me as a child was a very helpful and healing experience. I appreciated the group rules and the clear structure of the workshops. The preparation evening before and the sharing and integration the morning after the experience were very important parts to me. And the second quote is a man about 40 with an anxiety disorder, social anxiety disorder. I arrived in therapy with problems of self-esteem, distrust for other people, difficulties in my closest relationships, along with social anxiety and isolation. The group sessions with MDMA and LSD allowed me to touch vulnerable parts of myself, opening to and releasing patterns of negative thoughts and emotions that were obstructing and frustrating me. I regained a sense of well-being, happiness, and contentment, together with an expanded cartography of my mind and emotions. By melting frozen emotional states I carried with me, I realized I was not condemned to live in a state of negativity and emotional suffering. This gave me a perception of fluidity of one's own mind and tools for coping with the challenges of daily life. I gained confidence in myself, a greater understanding and acceptance for myself and other people, and a sense of fitting in my skin for the first time in a very long time. The group setting was fundamental to break barriers, expose myself, and learn about other people's own experiences, a cornerstone of my own healing. Sharing such experiences brought a sense of deep reconnection with other people and helped me overcome feelings of isolation and loneliness. I will never forget when in the first MDMA session I was struck by what it feels to interact and play like a child, careless and free. It was also the first time I could remember of having no anxiety while being with many people I did not know. The group setting was highly beneficial during my MDMA sessions, but all the more challenging with LSD, causing a lot of inhibition and retraction. I was many times unable to fully surrender to the experience and face the blockages I was being confronted with. This has made it difficult to work through and release the content that LSD brought to the surface, but it had the positive effect of making me stronger and more capable of withstanding challenging experiences. So, let me come to the end. My main conclusion is that psychedelic-assisted psychotherapy in groups is feasible and safe and works. So, this is not science, this is just my personal opinion of observations. So, what's the outlook? One big problem I had with patients is that they were on antidepressants. So it is quite tricky to taper them before, and usually it takes several or multiple sessions until they really get out of their depression, and you have to put it on again and to find the right time point to start again with antidepressants. This is an issue that has to be investigated, and we have to learn to deal better with it. So I'm looking forward to the registration of MDMA as a prescription drug. It might be a couple of years from now, and psilocybin will take a few years more. And I'm also a bit skeptical how fast this one will go. As I mentioned, the training of therapists is an important matter that has to be tackled and dealt with. And the question will arise as soon as we have the first prescription medicine, psychedelic prescription medicine, where should this happen? What will the authorities say where this can happen? Can it be in private practices, specialized institutions? What kind of hospitals can use it? Palliative medicine departments, or what? What makes me a bit uncomfortable is when I see how psychedelics are being commercialized. People with much money are coming into this field. I don't think if money is the right incentive or the right motivation to deal with psychedelics. Another thing that will be a question in the future is how can we personalize psychedelic-assisted therapy in the sense of which substance, at what time, in which dose, to which patient, to which disorder. When I think of addicts, it's clear that maybe ibogaine will be the better thing than LSD. This has to be investigated. Another question or challenge is what happens when non-dedicated, non-trained, non-convinced therapists start using psychedelics in their daily practice? I don't know. These psychedelics are being popularized, they are in the media all the time, and I've come across many people who try to treat themselves with psychedelics, and mostly it doesn't work. So the public has to be educated about this. Psychedelics are not a magical bullet that will solve the problems, but it needs all these four dimensions or perspectives of the sitter, the set, the setting, and a guide or therapist who is experienced. Thank you for your attention.